Hello, class. I'm going to start our discussion on hematology, the study of blood, and specifically hematopoiesis, which is the production of blood cells. We can change that name from hematopoiesis to something like erythropoiesis when we are talking about the synthesis of red blood cells specifically. You probably know this from physiology or even from your anatomy class. Blood is going to transport gases, oxygen, carbon dioxide, nutrients, hormones, wastes, anything that can be dissolved in the plasma. Blood is important for maintaining blood volume. It is also important for maintaining blood pH. And it's very important for maintaining the body temperature. Remember, most of the body's core temperature is shunted to the most internal regions of the body. Blood is also important with maintaining electrolyte levels. And we also recognize from our last chapter that blood is very important for maintaining hemostasis. That means the cessation of bleeding, when appropriate, of course. And the white blood cells are going to help protect us from pathogens. There are more liters of blood in the adult male than the adult female. On average, there's going to be about 4 to 6 liters of whole blood in a given individual. Again, males will have more than females. The average temperature of blood is about 100 degrees Fahrenheit. And it is true when they say that blood is thicker than water. Blood is about 5 times as more viscous than water. Can you tell me what makes up for the viscosity of blood? Well, it is the most abundant formed element that makes up the viscosity of blood. That would be the red blood cells. If the patient makes more red blood cells than normal, a condition known as polycythemia vera, or secondary polycythemia, their blood viscosity is going to increase, and this can increase the workload of the heart. A patient with anemia who has reduced red blood cells, well, that's going to decrease the viscosity. Blood pH ranges from 7.35 to 7.45, with the average value being 7.40. On either extreme, we can have changes in the pH causing denaturation of plasma proteins. Blood is also going to change its color when it's oxygenated, or 100% saturated, as we say. It's very bright red, as you can see on my little color swatch here. When it's oxygen poor, it looks more of a darker color. It's not blue like a lot of students think. The cyanosis that you see associated with poor oxygen content in a patient is from the pigments in the skin. Blood without a robust amount of oxygen is going to be more of a burgundy color. Whole blood is a mixture of plasma and formed elements. The formed elements, most of them are from the red blood cells, of course. Platelets and white blood cells are going to be less than 0.1%. In the plasma, we see mostly water. About 90% of it is water. Plasma proteins, the most abundant of which is albumin, and other solutes can be dissolved. In this picture shown here, I'm showing you a healthy picture of red blood cells and various types of white blood cells. You're seeing an eosinophil, lymphocyte, a monocyte, neutrophil, and a basophil. All of them are there. Plasma is mostly water, which is needed to transport all of the solutes that are dissolved in the plasma, both organic and inorganic materials. It helps retain the heat. Water has a high specific heat, so it can absorb a lot of heat before it rises in temperature by 1 degree, which is the reason why our blood is important in regulating body temperature. What is dissolved or suspended in plasma? There are proteins, about 7 grams % plasma protein content. That means 7 grams of proteins within 100 milliliters of whole blood. We see most of this comes from albumin. Albumin is very important for regulating osmotic pressure. We saw this in the incidence of kwashiorkor with a young child who was on a protein-deficient diet. The child was not making sufficient amounts of albumin. Therefore, the osmotic pressure in their blood compartment was reduced compared to their transcellular compartment. And that's the reason why we see the ascites occur in the peritoneal cavity. The albumins can be non-specific transport proteins. They can bind to hormones and other lipids to travel to basically transport them throughout the body. The other plasma proteins are globulins and fibrinogen, which of course we just learned in our hemostasis lecture. There are other regulatory proteins like hormones. The other inorganic solutes would be electrolytes like calcium, magnesium, sodium. Sodium is the most abundant cation and is the most involved in maintaining osmotic pressure in addition to the albumin. Organic nutrients like carbohydrates and lipids and some organic wastes are also found there. Organic wastes are going to include urea, which is a product of protein metabolism, uric acid, which is a product of nucleotide metabolism. Creatinine is a result of protein metabolism. Bilirubin, as you will soon see, is a result of red blood cell destruction. And ammonium ions, which are also a result of protein metabolism. This topic was covered in our body fluid compartment lecture. How does water move? Water moves for two reasons. One, a physical pressure on the fluid itself. This would be hydrostatic pressure shown here in the picture of you seeing the bottle of water. The water inside the bottle is exerting an outward pressure on the plastic bottle. Similarly, the plastic of the bottle is exerting an inward pressure on the water inside. So that's an example of hydrostatic pressure. This type of pressure explains why plasma moves through the intracellular clefts of the endothelial cells, out of the capillary, and into the interstitial space. But this type of water movement does not explain the driving force for water going across individual cell membranes, meaning passing from outside the cell to inside, or vice versa. Hydrostatic pressure and also osmotic pressure imbalance can explain why we are going to see shifts of fluid coming out of the capillaries and eventually ending up in special spaces like the peritoneal space. And this has everything to do with third spacing. Let me explain. In some of the old medical texts, the first space referred to is the first body fluid compartment. The largest of them all, of course, would be inside the cells, intracellular fluid. So that intracellular fluid was considered to be in the first space. The second space was the fluid found in between the cells, or interstitial fluid. The third space refers to the transcellular spaces, spaces lined by epithelial cells like synovial cavities, but most notably the peritoneal cavity, and that's something that I'd like to discuss more in the next few slides. What is osmotic pressure? It is the force to explain water shifting from one side of the cell membrane to the other. It is a difference in particle count per unit volume. So an osmotic force or pressure is created when and if there are unequal particles of solutes across the cell membrane per unit volume, and these particles cannot move across the cell membrane. They are impermeable. If we have a more concentrated solution in the extracellular fluid compared to the intracellular, then the water will move through the cell membrane by osmosis to the area with the highest particle count. Particles suck, as I like to tell my students. Now, these shifts of water in our patient's body fluid compartments can be very drastic. They are very quick and can quickly lead to death. A perfect application of osmotic pressure can be appreciated if we consider our plasma osmotic pressure being maintained by the plasma protein albumin. And when albumin particle count decreases, we are going to see that will lead to large shifts of fluid from one compartment to the next. and our patient will be, quote, third spacing, unquote. Let me explain on the next slide. If you review your capillary hemodynamics lecture from physiology, for some of you this might have been decades ago, you'll remember that when blood first enters a capillary at the arterial end, the capillary blood pressure is much higher than the capillary osmotic pressure. The capillary osmotic pressure is created by the amount of albumin dissolved in the plasma. There is a fight of pressures across the capillary membrane. There's capillary hydrostatic pressure, there's the interstitial hydrostatic pressure, there's the capillary osmotic pressure, and there's the interstitial osmotic pressure. Of all four pressures, the largest two are capillary blood pressure and capillary osmotic pressure. The capillary osmotic pressure is made or created mostly by albumin. Albumin levels should be maintained at a steady state, shown here as a dashed red line. However, blood pressure across a capillary drops. It's higher at the arterial end, as shown here by the green line designated as capillary blood pressure. If you look down at the x-axis, you see arterial end has a higher capillary blood pressure. Blood pressure drops as it goes towards the venous end. When there is a higher capillary blood pressure than osmotic pressure, there is filtration. There is a net loss of blood plasma to the interstitial space. This is great because it brings renewed, fresh nutrients. But as the blood pressure drops, then the capillary's osmotic pressure will be higher, and this will favor reabsorption. So you get some of that lost fluid back into the blood vessel. This facilitates the waste products from tissues to be picked up. Now, why is albumin and our discussion on osmotic pressure a perfect application or relationship to each other? Well, note this poor child's swollen, distended belly. She actually has a protein deficiency. She has kwashiorkor, which means disease of displaced or deposed child. And it basically means, loosely translated, that the child is no longer being breastfed. So now the child is put on a solid diet. Typically, they are eating a diet that is deficient in one of the essential amino acids, say, for example, tryptophan. So what happens is her liver cannot sustain adequate amounts of albumin. Albumin is a particle, and a significant particle in the plasma that helps contribute to the particle count. So she doesn't have enough particles, specifically albumin. This is because she is deficient in amino acid intake, and she can't make her own proteins appropriately. That means her blood plasma compartment has a reduced osmotic pressure, fewer particles per unit volume, and her peritoneal cavity, which is filled with fluid, a different kind of fluid, transcellular fluid, is not having this problem with particle count. So prospectively speaking, it has more particles per unit volume, and therefore this is going to create an osmotic effect. The water from the plasma compartment is going into the peritoneal cavity, causing the distension of her belly. She is not full. By no means is she full and feeling satiated from her meal. She is experiencing ascites, this edema in her belly. If you look at her feet, you can also see that the gravitational pull of blood to her feet increases capillary blood pressure, and this is going to help drive the blood from the plasma compartment into the interstitial space, but also because her plasma has reduced albumin. That means that her plasma water content is again additionally being driven into the interstitial space, attracted to the greater particle concentration. You don't have to go to a third world country to see kwashiorkor. You can see this in the elderly in hospitals and nursing homes because, well, quite frankly, the elderly can be really picky about what they eat. They can be deficient in certain amino acids. You can also see this in a severe alcoholic where they are not taking adequate amounts of protein and possible cirrhosis causing a lack of hepatocytes to make albumin. When do we do such a manipulation in a clinical setting? We manipulate plasma proteins from patients in order to perform the serum protein electrophoresis, or SPE. We put the proteins in a very basic buffer of about 8.8, and this makes the plasma proteins very negative. We put them on a piece of nitrocellulose and we apply an electrical current. We put the two ends of the cellulose in the buffer. As the electrical current flows, the proteins will be separated. Again, when do we want to manipulate plasma proteins in a clinical setting? When we want to separate them according to their electrical charges. We can analyze proteins in plasma. We can even analyze proteins in this fashion that come from urine. The current goes from a battery pack, transfers through the buffer, and through the wet nitrocellulose. We can then stain the proteins. When we put the protein on a piece of nitrocellulose paper and apply an electrical current, you'll see here that if the proteins were put in a buffer that was very, very basic, shown here as deep purple with a pH of 10, that overall the proteins would be deprotonated and be overall negatively charged. And therefore the proteins would travel towards the positive part of the electrical source. It would travel toward the anode. If, however, we put the proteins in a very acidic buffer, then the proteins would be highly protonated and therefore positive, and so these proteins would move to the negative pole, or cathode. If proteins are neutrally charged, then they would not have any net migration to any pole of the electrical source. Here is a typical profile of an SPE. The most abundant plasma protein, as I said before, is albumin. It's going to have the largest band. The next band to your right is alpha-1 globulin. These consist mostly of an enzyme known as antitrypsin. Then the next band will be alpha-2 globulin, which are primarily your macroglobulin and haptoglobulin. The next band will be your beta globulins, and it includes your beta 1 and beta 2 globulins. The last band is your gamma globulins, your immunoglobulins. You know, your IgGs, IgAs, IgEs, IgMs, and IgDs. I'm sure you remember these from microbiology. You remember things like M for mega because it was a really big antibody and had 10 binding sites. Or you might remember things like IgA for saliva and tears and sweat. All of those words have the letter A in them. So you think of body surface secretions. Now, they are supposed to be in a normal ratio. Most importantly, there is a ratio between albumin and the gamma globulins. Albumin is in the numerator, and the gamma globulin fraction is in the denominator. So obviously, if you are looking at this normal picture, the albumin part is much larger than the gamma globulin. So the fraction that you get between the two of them will be slightly larger than 1. What is significant about this? The width of the bands can be diagnostic. They can indicate a number of conditions that the patient might be suffering from. It all relates to the albumin-globulin ratio. Again, albumin being larger, this is going to be a normal value of higher than 1. Albumin is much larger than any of the other protein fractions, so we want the AG ratio. Different diseases will have varying AG ratios. The densitometer shines light at these bands, and depending on how dark they are, will measure how much light is transmitted through the paper. If a patient had a high gamma globulin fraction, a higher than normal gamma globulin fraction, then our ratio would decrease. This would be indicative of some sort of infection, right? Because that is what our immunoglobulins do. They fight infections. That's one of the more common uses that we use the electrophoresis for, is to see this Ag ratio. I'm showing you again a normal electrophoresis pattern in the top picture, and in the bottom picture I'm showing you an abnormal electrophoresis pattern. Again, this SPE is total protein test. It is often ordered as a routine health checkup. Total protein may also be ordered to provide general information about a patient's nutritional status, such as when you might have undergone a recent weight loss. This test can also be ordered along with other tests to provide information if you have a patient that might suggest a liver or kidney disorder. Because if the liver or kidneys are failing, this too can explain edema. Low total protein levels can suggest a liver disorder, as I just said. The liver is responsible for making albumin. If it's a kidney disorder, like the kidney is not secreting enough sodium or retaining enough sodium and water, this can lead to a problem with the protein concentration. Another example, if the kidney filtration membrane is damaged and protein is being filtered and lost in the urine, then the amount of protein in the blood would decrease. For more examples, we can see low levels in severe malnutrition, with conditions that cause malabsorption, such as celiac disease, liver disorders, kidney disorders, etc. We can see high total protein levels with chronic inflammation or infections. Again, the IgGs would go up because of that chronic inflammation. The cytokines would cause more of these plasma proteins to be produced. So laboratories are going to report the Ag ratio, or albumin to gamma globulin ratio. As I said, a low Ag ratio may reflect an overproduction of gamma globulin or loss of albumin, and a high Ag ratio is going to suggest underproduction of immunoglobulins, maybe as a result of various white blood cell disorders. Maybe this is new for you, or maybe this is review, but where we have hematopoiesis, or synthesis of red blood cells specifically, the locale shifts throughout our development. In the early months, the embryonic months, hematopoiesis is occurring in the yolk sac, as you can see here. And then, as the fetal period begins, we see a transition from the yolk sac to the liver and spleen, primarily the liver. And then before birth, we are going to, again, see a shift in locale. And this time it's to the bone marrow, the medullary cavities of the long bones specifically. But as soon as you reach, well, a little bit prior to age 20, we are again going to see a shift in hematopoiesis. We lose the red marrow in our long bones. The medullary cavities of the long bones will be replaced by yellow marrow, which is fat. And you see there is a shift from the appendicular skeleton, the long bones, to the axial skeleton. In other words, hematopoiesis is going to occur in the vertebrae, in the sternum, in the ribs, and even a little bit in the iliac crest. So it's all downhill after age 20, folks. When we speak of erythropoiesis, we are starting with the hemocytoblast, which is a multipotent stem cell. Multipotent means that it can replicate and divide and give birth to many different types of daughter cells. The first branching from this hemocytoblast cell will either be the myeloid stem cell or the lymphoid stem cell. The myeloid stem cell can give birth to daughter cells that will ultimately differentiate into erythrocytes, or the granulocytes, like eosinophils, neutrophils, and basophils, or monocytes that will differentiate into macrophages, or the megakaryocyte, which of course we already learned generates the platelets. The other type of stem cell line is the lymphoid stem cell line, which will propagate T cells and B cells. So we say multipotent, again, to refer that the hemocytoblast is determined, meaning already it has selectively turned on certain genes and turned off other genes. And it can give birth to many different types of daughter cells. But as we go from left to right in this picture that we see on the screen, there is more and more differentiation. What exactly is the recipe for erythropoiesis? Well, we need, of course, to start with a healthy stem cell. We need healthy hemocytoblasts. There needs to be chemical signals that promote the daughter cell from the hemocytoblast, from the myeloid stem cell line, to actually go through the phases of erythropoiesis, to go to a proerythroblast, to a basophil erythroblast, etc., etc., to a reticulocyte, to an erythrocyte. So we need good growth inducers like interleukins, which are cytokines. We need differentiation inducers, again, various types of cytokines. They're all chemical signals released by adjacent cells to direct the hemocytoblast and its daughter cells. We also need good cell division. The hemocytoblast needs to replicate its DNA and then divide. There needs to be healthy amounts of nucleotides to promote DNA synthesis, because the S phase in mitosis precedes the actual mitosis phase, or M phase. That means we need good DNA replication, and in order to do that, the enzymes of DNA replication require vitamin B12 and folic acid as coenzymes. I will review what a coenzyme is in a different segment when I talk about anemias. Obviously, if erythropoiesis is to occur properly, there needs to be good hemoglobin synthesis. I'm going to talk about assembling the components for hemoglobin. I'll talk about the synthesis of heme. I'll talk about iron. And I'll talk about the globin chains and gene expression of them and how we have different types of globin chains throughout our development. Erythropoiesis takes about 5 to 7 days. It takes about that long to go from the hemocytoblast replicating and dividing to form daughter cells that enter the myeloid stem cell line, all the way through to the development of a mature erythrocyte. So the earliest cell that we see is a proerythroblast in the erythropoiesis stages. This is now a cell that is determined to differentiate into an RBC. And it's going to go from the proerythroblast to the basophil erythroblast, etc. It's becoming more and more differentiated. And in each of these phases, the cell is focusing on making large amounts of hemoglobin. Hemoglobin will be the most abundant solute inside the cytoplasm of the mature red blood cell. We recognize that it is the reticulocyte that enters the circulation. A reticulocyte should not be more than 1% of all red blood cells. We know that the reticulocyte does not have a nucleus, but it still has remnants of RNA and endoplasmic reticulum up until the very last moment. The cell is still focusing on making as much hemoglobin as possible. It takes about 1 to 2 days for the reticulocyte to mature into a red blood cell. Why is it important that red blood cells lack mitochondria? Well, one of their jobs is to transport oxygen. And if red blood cells have mitochondria, then that means they would be able to be capable of aerobic metabolism, which is, of course, the oxidation of glucose to synthesize ATP. And then that would mean less oxygen released to the tissues of the body. So the poor little red blood cells take one for the team, and there's a trade-off for their robust ability to transport oxygen. They are relegated to anaerobic means of making their ATP. So that is the reason why they don't have mitochondria, so that they can transport more oxygen and have more oxygen delivery to the tissues of the body. Hematocrit is the percentage of red blood cells to the total volume of blood. When we measure hematocrit, it is in a heparinized tube, a hematocrit tube. We measure in millimeters the distance of the packed red cell volume, and we divide that by the distance of the entire blood sample in our tube, also measured in millimeters. And then we would get the percentage of red blood cells. Again, men will have a higher hematocrit than women because they have more blood volume. But then also, the testosterone that they make stimulates hematopoiesis, specifically erythropoiesis in the bone marrow. Hemoglobin concentration is the amount of hemoglobin in a 100 milliliter sample of whole blood. Again, the normal range is about 14 to 16 grams percent, with the average value being 15 grams percent. Males, of course, being higher than females. For every gram of hemoglobin a patient has, there is 1.34 milliliters of oxygen that can be transported. We can multiply a patient's hemoglobin grams percent by 1.34 milliliters to determine their oxygen carrying capacity. On average, there is 20 milliliters O2% oxygen carrying capacity for an individual. That's how we express the units for oxygen carrying capacity, mil O2%. And the percent means per 100 milliliters of whole blood. Another review of your red blood cell indices is warranted. It's so very important to have these down like the back of your hand before you start your professional schools, whether it be nursing school or physical therapy or PA school. MCV stands for mean corpuscular volume. Again, that should be between 80 to 100 cubic microns. Mean corpuscular hemoglobin, or MCH, refers to the weight of hemoglobin in a single red blood cell. It should be 32 picograms. Another way of writing that is 32 micrograms. That seems to be a more antiquated way of writing the units. Nowadays, we just say 32 picograms. Mean corpuscular hemoglobin concentration, or MCHC, refers to the concentration of hemoglobin with respect to the volume of a single red blood cell. So it's a solute to solvent ratio. It's the amount of hemoglobin in a single red blood cell divided by its volume. So that's about 34%. Mean corpuscular diameter, or MCD, is about 7 to 8 microns. And color index is basically a visual determination of how red the red blood cell looks. If there's adequate amounts of hemoglobin inside the red blood cell, we give it a color index, or a CI, of 1.0. If there's 50% less hemoglobin, let's say instead of 32 picograms, we have 16 picograms, well then we would give the red blood cell a color index of 0.5. We need to review some terms because in a subsequent segment, I'm going to review different types of anemias, and we're going to see that with various types of anemias, we can get changes in cell size or cell shape. The term chromasia is going to be an indication of how much hemoglobin is in a single red blood cell. Again, this has to do with that color index that I just told you about. So if we say that cells are hypochromic, you should instantly be thinking that there is reduced color index because of a reduced amount of hemoglobin within that single cell. Hyperchromasia is really only going to apply with hereditary spherocytosis. And I should caution you with this one. A lot of times students think when a cell has hyperchromasia, it's because the red blood cell is overstuffed with hemoglobin, too much hemoglobin. And really, in the synthesis of red blood cells, you don't get an overabundance of hemoglobin packed into the red blood cell. We'll see that there is going to be a special case in hereditary spherocytosis, but I think you'll see when I get there that it's not from an overproduction of hemoglobin, but rather from a red blood cell that's decreasing in size over time. When a red blood cell is described as normochromic, that means that it has an adequate amount of hemoglobin packaged in it. The term anisocytosis refers to cells of abnormal size. That means you should be thinking of changes in mean corpuscular volume. When we say a cell is microcytic, that means it's too small. When we say it's macrocytic or megaloblastic or megalocytic, that means those cells are large cells. Normocytic means that it's of normal size. Again, that would be 80 to 100 cubic microns. Poikilocytosis means cells of abnormal shape. We're going to see abnormal shape with a few types of anemia. We're going to see poikilocytosis with sickle cell disease, for example. Just to remind you that our red blood cell production should be maintained at a steady state. That means the synthesis of erythrocytes should match the rate of removal of the erythrocytes in the liver and spleen. And I gave you a bathtub analogy of that. If you were to fill up your bathtub halfway full and then match the inflow from your faucet to the outflow from your drain, and then leave the water going overnight, your bathtub volume should stay the same. But the next day when you come to your bathtub, I hope you would recognize that the water molecules you have there in front of you are different than the ones you had the night before. There's constant synthesis of red blood cells, new reticulocytes entering the bloodstream, being matched with the removal of dead or dying red blood cells. Red blood cells live for about 120 days. There is a reason for this. They don't have any organelles, and they sustain a lot of damage while in the circulation. They sustain a lot of oxidative damage, particularly to their membranes, and this means the red blood cells are less flexible. So they're going to get hung up in the reticular fibers in the liver and spleen and be removed by the macrophages. More on this soon. Red blood cells have a biconcave disc. This is going to increase their surface area, which allows more rapid diffusion of gases like oxygen and carbon dioxide. And this biconcave disc allows them to literally fold in half. You see the red blood cell, although it only has a diameter of 7 to 8 microns, many capillary beds in the body are smaller in diameter than that. As such, the red blood cell literally folds over on itself, as shown here in the top right picture. Red blood cells are membranous bags of hemoglobin. That's their most abundant solute in their cytoplasm. There are other solutes, of course. There are enzymes and other types of structural proteins, but hemoglobin is the most abundant, which is necessary to transport oxygen and also carbon dioxide. If you were to make a little period at the end of a sentence, in that volume, you would have about 5 million red blood cells per microliter. And it's just so remarkable that we would have 5 million red blood cells in just 1 microliter. They truly are the most abundant cell type in your body. 1/4 of all your body's cells are red blood cells. Now, just a quick review. We remember that erythropoietin, EPO, is a hormone that is primarily released by the kidney, 90%, with 10% coming from the liver. The kidney detects hypoxemia, which is low oxygen content in the blood. If there is renal failure, then we would have decreased EPO, and a patient would present with anemia. So you need EPO from the kidney. The actions of EPO increase stem cell mitosis to the hemocytoblasts, meaning they replicate and divide more frequently. There is a greater release of reticulocytes into the cardiovascular system, and there is an increase in red blood cell number in about 5 days. We do have recombinant human EPO. This has led to a lot of the sports venues having a problem with people doping on EPO because a person with more red blood cells can carry more oxygen, which means they are in an aerobic state longer. And that can mean the difference between winning a race and losing a race. So a lot of the sporting venues have put a cap on hematocrit. Many of them say if your hematocrit is more than, say, 50 or 52%, then you cannot compete in this activity or competition. Here is the feedback loop that allows the kidneys to regulate red blood cell numbers. Kidneys detect hypoxemia. They do have oxygen sensors. When they detect a reduced amount of tissue oxygenation, they release EPO. This will stimulate the hematopoietic stem cells, the hemocytoblasts. This promotes more of the daughter cells entering the red blood cell lineage. More cells enter as pro-erythroblasts, and this will lead to more reticulocytes released into the bloodstream. And then following their maturation, this will increase the red blood cell count. What could reduce oxygen levels in the blood? Many things. Low blood volume, of course, because you would have a reduced oxygen carrying capacity. Anemia, where you have reduced red blood cells. Low hemoglobin, poor blood flow, or pulmonary disease. Maybe you can't get oxygen to cross your respiratory lining. I have a picture up here of a mountaintop. Obviously, if you were going to go to higher elevations, there would be reduced oxygen content in the atmosphere, and this too would be detected by the kidneys to stimulate EPO release.